Pardon?
Botswana does better. I told you. All right.
Well, we're going to leapfrog them in the next
Let's see. All right, let's see. Okay, healthcare reform, health reform, alternative. What is you know, again, if
Can we put those steps behind that frame?
you got it. Thank you, sir. Welcome, welcome, welcome to Health Issues. I'm your host, Chris Sylvain, and believe me, we are so excited and honored today. We have a great subject, great guests, and believe you me, we have Mr. Bruce Greenstein. He is the Secretary of the Department of Health and Hospitals, the state of Louisiana. Welcome, Mr. Greenstein.
Thank you. It's great to be here.
Well, we are excited to have you, honored to have you, and of course we have a lot to talk about in this day and time, but a lot of people don't really know who you are. You have an extensive resume, extensive experience with Microsoft and a company called CNSI. Tell us a little bit about yourself.
Well, most of my experience professionally has been in the public sector.
Okay.
I've worked for state government, and I've worked for Congress and the executive branch for many, many years.
Mm-hmm.
I'm an economist by training.
Right.
My last two jobs have been in technology, specifically in health information technology.
Right.
CNSI is a systems integrator in Washington, D.C., and they work with states around the country, successfully implementing modernization for states and claims payment systems. Mm-hmm. And Microsoft, of course, everyone knows. I had a great opportunity over the last 5 years to run an international business unit doing healthcare with governments and health systems around the world, and basically helped address some modern day problems with automation of large systems, approaches to public health, doing healthcare reform in many other countries as well. And it's given me a great perspective to see how other countries do things successfully or otherwise, and be able to apply those lessons in my job here.
Awesome. A couple of examples, a couple of countries of some of the projects that you jumped into, maybe.
When I think about states that do a really good job of coordinating care,
Okay.
and that's between primary care, acute care, and then post-acute and back to home, I think about the Netherlands and Denmark do it exceedingly well.
Yeah, okay.
They have advanced use of technology for electronic medical records, and they make that whole continuum of care a continuum of care.
Awesome.
Still, many other countries are challenged with technology. I was in China about a year ago, and many hospitals lack digitization of their health records. It's still in paper.
Right.
And when you go from, say, a village clinic to maybe a town hospital, then maybe you need something more substantial in a city that'll have tertiary care,
Right.
there's no way for those records to follow.
Wow.
And in many cases around the United States, it's like that as well. We still rely on the paper record or the fax as ways to transmit information. Here in Louisiana, we're actually one of the fastest states in terms of adopting health information technology to help us. We're the third state in the nation here actually to issue payments to facilities for using information technology in Medicaid.
Awesome.
So it's great that I get to use that experience from around the world here in Louisiana.
Hey, that's really, really good. And do you see a direct comparison between systems and outcomes?
Yeah. Whether it's in patient safety or in follow-up or efficiency, both at the clinic level and at the hospital level, we see that there is fewer duplication of tests being ordered or imaging being done, less time by clinicians looking for information, and that's probably one of the best efficiency gains. And then for people that are being served, we're seeing things that would otherwise be maybe contraindicated or duplicative or something that was not seen in one initial exam, but it was in an electronic record from before that was being able to be spotted. And that's a help. And if you look at how hospitals have been adopting technology over the last 10 years, you can see the efficiency gains and the outcome gains. And now we want to spread that to all hospitals and all clinics around the state.
That's amazing. And let's say you had an opportunity to climb a few mountains while you were traveling.
Yeah, it was. I'm a mountain climber over the last 20 years, and having lived in Seattle was a great opportunity for me to put my volunteer hat on. I was the head of an organization that raised money for avalanche centers.
Okay.
I was in mountain rescue, rescuing people in the mountains in snowy and in the summertime.
Wow.
And when I got to travel with Microsoft, I spent time in the French Alps and in other mountain regions around the world on the weekends, enjoying my time.
That's so exciting, because we've interviewed Dr. Ben Sachs from Tulane a couple of times, and that was one of the greatest things that he loved. This escapade called climbing mountains.
Before I even got a chance to meet Dr. Sachs in person, I had already heard that he was a mountain climber. We would hit it off as soon as we met, and we certainly have. We've become good friends, and hopefully we can climb some mountains together.
Hey, that's an idea. That's an idea. Awesome. The thing then, looking at the experience, Microsoft and mountain climbing around the world and so forth, and now Baton Rouge. How do kids like it?
The kids love it. I have two girls, Kennedy and Kyla, 7 and 10 years old, and they're in 2nd and 4th grade. They've recently started school. The thing that they see that's different from being in Seattle to being here is just how friendly people are. Kids are genuinely nice, and there's not a lot of conflict on the playground or in the classroom. The teachers are absolutely splendid, and the schoolwork, you would think maybe with a lot of engineers in Seattle that it would be harder in school there. Actually, the kids are finding the work more advanced and more takes more of their homework time when they get home doing the schoolwork here in Baton Rouge. So the kids are having a great time, and consequently their mom, my wife, is also loving being here as well.
You're a smart father.
No. Yeah.
And husband. And that really, really works. And this wasn't a set question, but I have to throw it in. LSU and Tulane. All right, you don't have the answer. You're a smart man.
Hey, on Saturday, I'm always rooting for LSU. That's all I could say.
Okay. That's a good deal, good deal. Now look, something we'll looked at, and it's a major proposal, and we'll be talking about it, but this idea of working Secretary of Health and Hospitals, and we appreciate you, and administration, Governor Bobby Jindal. But when we look at this concept of caring for the poor, it was former President George Bush, who made the point. He put a major investment in AIDS in Africa. Huge. I mean, it literally changed the specter of AIDS in the country, in a continent that was losing so many people, and made a major difference. His point is that we have to care for the least of these. What do you think about that reasoning?
I think that we have a responsibility as Americans, and as our country is in the club of wealthy nations, that we have a responsibility to continue to help nations that are not as fortunate and are facing challenges that are too difficult for those countries to face on their own. I was lucky to be a member of Microsoft when Bill Gates was there. And Bill Gates has left the company, taken his own personal wealth, and made major investments around the world in global health, among other things, including education. The responsibility for wealthy nations is to continue to make investments in foreign aid to countries that has very substantial returns on investment. And what we hope to get out of that is to improve the quality of life of people, to improve the infrastructure of countries, to improve stability in those countries. And when we think about AIDS, whether it's investments made in the United States through the administration or through organizations like WHO or Gates Foundation, those have very real impacts. Just talk about what the results have been. In the last 10 years, 20% decrease in the number of people contracting AIDS. Over the last 5 years, 20% decrease in deaths caused by AIDS. We have to continue that level of investment. Our goal is to see that no one has AIDS, and there can be a legitimate vaccination So, and that's going to take investment in the development of it, and then clinical trials to make sure that it works exactly how we need it to work, and then to begin education and outreach so that countries are able to implement their own programs over time. So I applaud that effort, and I'm very strongly supporting it going forward.
Well, that's awesome, and that fits right along with the next question. You know, when we look at, again, you know, and we're going to talk about the Medicaid proposal in a second, but truthfully, it is a Republican administration, you know, and it seems as though it's sweeping much of Louisiana at this point. But let's look at the African American community. Probably, in values, probably the most right-wing group of people you'll ever find. I don't know too many friends that would be against somebody taking their gun control. I think they would laugh at you saying, "Are you really going to take my gun?" If you lost your mind, you know, prayer in schools, you know, abortion, taxes, you know, school choice, private schools. I think in almost every area, conservative is the most conservative you'll ever find in life. They will kill you over prayer in school. They will pray anyway. I mean, you know, that's just the way it's going to be. And but still, the rarity of anybody to even be found near the Republican Party, because the obvious thing is the assumption and the thought that the inherent belief of many in the Republican Party of the lower intellect, the lower IQ of the African Americans. So you have this schism. So African American is sitting with Democrats that don't have the same belief in gay rights and everything else like that. And I mean, what's your thoughts?
The way I look at the proposals that we put out for healthcare is to address everyone's healthcare issues. We don't see that there's Republican health challenges and Democratic health challenges, that there's black health challenges and white health challenges. Okay. I look at our state being 49th in the nation for health outcomes on a variety of national measures. And I see that our state needs to have a solution to problems, and it's everyone's problem. It's in every community across the state. It impacts the way, if we don't have healthy kids, we don't have highest performing students in school. If we don't achieve that, then we can't have as competitive as an economy as we really want. The proposals that we're bringing out today, interestingly enough, are not the domain of only one party. They're just the right public policies moving forward for anyone in the state. We'll continue to move forward on this agenda that's been going on for the last several years, whether it has to do with improving pay for performance in healthcare programs. It's putting more resources in the community where healthcare should be delivered most. And in this final piece, coordinated care networks, it's having a choice for people to choose what network of providers they want to get their health care from, so they could achieve their ultimate goal, which would be to improve their health outcomes.
Okay, let's go with it. Next point. Concerning these coordinated care networks, this Medicaid proposal, just for those that may not know, you guys have a major initiative to change the way Medicaid is paid for and operates in the state. It will affect a lot of people, tons. There was an article in the paper, Dr. Ben Sachs, who talked about before, you know, greatly admire, that this would totally change healthcare in Louisiana. Instead of people going around waiting until they're half dead before they hit the hospital, there's a physician that'll be there for them. Can that truly be true? Can we really affect outcomes unless we start looking at family structure, divorce rates, infant mortality, at least kids born out of wedlock, or just poverty in general, socioeconomic conditions, jobs? Can we really make a difference? I mean, are we really just blowing smoke?
So let's take a little bit of time and lay this out, because I absolutely do think that we can make a difference. Another one of your participants on the show, Dr. Karen DeSalvo, often says that 70% of health is socially determined, not coming from the interaction with the physician, but as I like to say, it's a supply chain issue. It's what's happening early in life all the way through.
Okay.
We've made some major changes over the last couple of years in the Medicaid program. And the Medicaid program today serves 1.2 million people. It's over a quarter of our state's population.
Right.
We haven't made many major changes in that program since it came online in 1967.
Okay.
Today, when we think about, we'll go to one of your issues that talked about births, we're among the worst in the state. We recently received an F from the March of Dimes on prematurity. We have one of the worst infant mortality rates in the country, and we have one of the worst low birth weight baby rates.
Mm-hmm.
And that's clearly a supply chain issue.
Mm-hmm.
65,000 births every year in Louisiana. We have about a flat fertility rate. This year, Medicaid will pay for over 70% of those births. It's imperative that we make changes to improve birth outcomes in our state if we're going to build a stronger Louisiana. Mm-hmm. So let's talk about a couple things that we've done. First, we have a program that serves about 900,000 people that provides a small fee to physicians, the primary care physician of Medicaid enrollees, to sort of oversee their program. Okay. We changed that in January to make it a pay-for-performance program. Okay. We want to expand access. We want to reduce the number of times that an individual goes to the emergency room. We'd rather them see their physician. Okay. That's the first change in the way we're thinking in that relationship between the patient and physician. Mm-hmm. The next is right here in New Orleans. It's the Greater New Orleans Community Health Clinics. Okay. Again, that Dr. DeSalvo, the godmother of this program, we were able to make a $100 million investment to create medical homes, mm-hmm. to give individuals a place in their community to go see a physician and have a relationship with the health center in that medical home model. The idea is that we don't rely on hospitals as the source of primary care. Okay. That's an expression of what our values are in the health system. That's how we think it should look and manifest itself. Right. And that relationship that involves personal responsibility on behalf of the individual, mm-hmm. to go and see a physician, be proactive with their health, and listen to what their physician says that they should do mm-hmm. In terms of compliance. And the last piece is, and this is what's called the coordinated care networks. Mm-hmm. It's about 830,000 people will be enrolled, and people will make choices. For the first time, whether you're in New Orleans or in Monroe, you'll have a choice in the health plan that you want to join. Mm-hmm. You want to stay with your primary care physician, you'll be able to do that. You want to go to a certain hospital, you'll be able to go and do that. Mm-hmm. But the point is those great challenges that we see in the communities, whether you're a single mom and you have a couple of kids, and you're trying to get health care for yourself, and your kids have, say, a periodicity table to maintain, and you're trying to make ends meet, it's difficult to navigate the health system. To have a health plan that will be proactive in helping you. Maybe one kid has diabetes and needs to be have some disease management to avoid having to go to the emergency department. Mm-hmm. Maybe one of the children has asthma, mm-hmm. and it could be managed in the community and in the home far better than having to go to the emergency department. Okay. We've never had that opportunity. We never had disease management, patient navigation. We don't have somebody that proactively does prevention. Mm-hmm. We have a health care system that's really a treat the sick system. We don't have something that promotes wellness and health, and that's what we're trying to move to in this plan.
It sounds good, and I agree. A statement that you made earlier, that every system is gets the outcomes it was set up to have, or whatever way it went. But and we have a system that's designed to do what it does, and we have a lot of sick people here. But on top of that, though, we have a group, and I am partial, and for transparency, I'm married to a social worker. Okay, but we have a professional that's there to actually deal with those problems of poverty and access that's so prevalent in society, but I don't see in any plan where they're designed to really jump in these primary care clinics and see people and make a difference.
Yeah, actually, that's a very good point. And so let me tell you about some of the things that are happening right now that you might not be aware of. In the Greater New Orleans Community Health Clinics that function as a medical home, there's often social workers, sometimes clinical social workers, that do the navigation for the individual. Instead of treating physical health in one location and behavioral health in another, the idea is to bring that together. And it's made possible through social work activity that happens at the center or at the clinic. So by bringing those two together, we're able to make the process more efficient and save money, but more importantly, we improve patient outcomes and we improve the quality of life of individuals. In terms of coordinated care networks, those that do the patient navigation, the case management on the phone, that oversee a patient's care needs, many plans employ social workers to do that, to do the navigation of all the parts of the system, to make it work for the patient. Because when the health system works for the patient, it ends up being less expensive in the long run. But we've never had that incentive. There's never been one entity that would enjoy the savings to be able to use on other services. When you allow a health plan to do that and bring the money together, they finally have the incentive to work that way. So these are things that you should be quite happy about.
Really, and I need to go. I wanted to go here and bring this into these notes, and because hospitals vehemently oppose to this program.
Let me just stop you right there.
Okay, go ahead. Go ahead.
There may be one or two hospitals that are still not happy about changing.
Okay.
And my suspicion is they would be interested in protecting the status quo rather than in changing no matter what.
Okay.
And I might not have the opportunity to convince them otherwise.
Okay.
But we have spent a great deal of time with hospital leaders across the state, including the Louisiana Hospital Association, that just last week issued a letter in support of the concept of coordinated care networks. We've spent much time with the hospital CEOs from the New Orleans area that are also in concept very much in support of coordinated care, and many times have the most amount of experience with managed care than any other hospital area in the state, right here. So from the start, hospitals, maybe perhaps a year ago, when the department didn't do as good of a job of education as we could have, we've spent the last year really focused on allowing our people to go out, spend time in the community and with our stakeholders, to work closely to find out what works and what might not work, and then make changes in our plans so that we could bring the hospitals and physicians in, and everybody would be pleased with the final product, which is what we have today.
So right now you have all systems go. You guys are ready to, there's no, because if hospitals are on, then everybody's on.
That's right.
Question, because there's a couple more keys in. One, with insurance companies taking a dominant role, and I think insurance companies have them and used car salesmen, I don't know who has the better. But that becomes the question. Can we trust that the plans that you have laid out will go forward?
So first thing, there's two different options within coordinated care networks. One will be a familiar insurance model, and the other will be a plan that we call shared savings. So it'll be an organization. We suspect there'll be quite a few that are provider-based, maybe a group of hospitals and physicians that get together and form a care management organization that provides a network. So about half of it will be insurance companies, half of it will be, we expect, provider-sponsored organizations. For your concern, which is around insurance companies, I might trust people who I know, but organizations we regulate. And in this case, we have a very, some might call it severe, but we have a very heavy hand with data collection, with oversight, with grievance and appeals. There'll be no there's no slack in the system on this. There's going to be a great deal of oversight, especially in the first couple of years. We're going to be very heavy-handed with the way that we watch, we look for outcomes, and collect data. We want to make sure that when we launch this, we launch it with an A, not a C or a D. We want to get good grades right from the start, and we're going to be very active in assuring that we get the outcomes that we're looking for.
Hey, it all sounds good, and I think that's where the question became, somebody proposed that why couldn't nonprofits do this, again, for not trusting the insurance companies?
Sure. We expect that there'll be some nonprofit insurance companies that participate, and if they can compete and offer the same benefits, then they could win in the RFP process. But keep in mind, though, we somehow stigmatize the for-profit versus the not-for-profit.
Okay.
And I think both can provide equally important benefits. Just remember, in our state alone, we have about 250 hospitals. I don't know if you knew this, but about half of them, a little bit more than half, are actually for-profit hospitals.
Right.
When it comes down to large acute care hospitals, over a third are for-profit.
Right.
And when you look at the number of beds we have, it's a substantial number of beds in our state are under for-profit hospitals. Now, we don't do a lot of complaining when we go to the hospital that it's for-profit. We go, if we get good service, we go back.
All right.
Otherwise, we go to another hospital. If we don't get good service at a not-for-profit, we might go to a for-profit. So we shouldn't look to stigmatize the ownership status of either an insurance company or a hospital. We should demand absolutely highest quality that we can get,
Okay.
and then if we don't get that, we go somewhere else.
Okay, sounds good. That's another program. Your thoughts on the uninsured? Let's throw that out.
Uninsured, very interesting in our state that we have 20% uninsured, and we've built a whole system to provide care in a systemic way for the uninsured population. Other states that I've worked in, say Massachusetts for instance, started out with 6% uninsured and then had a massive healthcare reform to address the 6%. We have so many uninsured in our state that we have a whole hospital system that was designed and grew around providing care and services, which I think the LSU system does a very good job. We have to contemplate what that system does and how the uninsured get taken care of in 2014. If everything continues to go forward with healthcare reform, then almost all of those people will have health insurance, and a majority of those people will be enrolling in Medicaid. So when I think about the uninsured, I think about quite a large expansion in the Medicaid population. In 2014, we'll have community care, or we'll have coordinated care networks established, and people, when they are eligible for Medicaid, will have the ability to join a coordinated care plan with lots of choices for the first time in their life, and I think it'll be a great day.
Okay, that's an awesome answer, and I'll have to flip back. We just have a couple of more minutes because I got to flip to this last question that we'd already talked about, because I love the answer, and it sounds great, because 2014 we're expecting to have, health reform rolling in, but the state of Louisiana and our Attorney General Buddy Caldwell and Governor and so forth are having a major battle against health reform, and then
So I'm going to continue to let the legal experts and people in Washington, D.C. play this out. I'm an administrator. My role is to be prepared to implement what the law of the land is. I can't take the risk of not preparing and thinking about what may be the case in 2014. Otherwise, I'd be letting the department down and letting the people of Louisiana down. So we're continuing to work, do analysis, and understand what would bring to the state in 2014 if the law stands as it is. I could tell you that today, as I mentioned, we have 1.2 million people on Medicaid. In 2014, our forecasts show that 467,000 new people will join the Medicaid rolls. So that's an increase of about 40%. And over the next several years, we'd be up to 600,000 new people. That would add, after the second year, a considerable cost to the state in terms of financing that Medicaid expansion. Furthermore, in 2014, of the 467,000, 187,000 of those new enrollees will have come from private health insurance rolls.
Wow.
So people will basically be turning in their insurance card where they've had to pay premiums and so forth to go on Medicaid.
Sounds good. I'm excited. Hey, I think you keep this show, Mr. Bruce Greenstein, Department of Health and Hospitals, Louisiana. Keep fighting as hard as you can. Keep watching the show, Health Issues. We thank God for you. Have a great day.
Thanks very much.
Appreciate you. Absolutely.
Thanks very much.
I really do. I wish you well.
I need all the well wishes I could get. It's a tough job.
No, we do. I think so, and about in the interview that I wish it was all so nice.